Good afternoon. My name is Dr. Thomas Yoon, and I'm your final presenter for the 2022 Osstem meeting in Seoul, Korea. It is truly an honor to be here today and to be a part of this meeting. I would like to express sincere thanks to the Osstem team for having me for today. A little bit about myself. Again, my name is Dr. Thomas Yoon, and I received my dental degree in Missouri, Kansas City in 2001. I obtained a certificate in hospital dentistry at St. Louis Barnes Jewish Hospital and Washington University in 2002. I then went to University of Florida and got a fellowship in oral maxillofacial surgery, and then went on to continuing training in periodontics in 2006. Received my board status in 2007, and then just to get some more education, I decided to get a degree in Master's of Health Service Administration from the Lake Erie College of Osteopathic Medicine in 2018. I teach currently at LECOM School of Dental Medicine, where I am the Assistant Dean of Clinical Education. And as the Assistant Dean of Clinical Education, I see a lot of patients here, and my students see a lot of patients here. And one thing that my students are really adamant about is learning about dental implants and dental implant restoration. Now, I tell them all the time, look, dental implants are here. Dental implants are something that we need to do. And my students absolutely agree. But I also inform my students that when the patients come in with a series of expectations. And when we look at the expectations from a patient perspective on implant dentistry, there's three things that they look for. Number one, they want the implant to be placed accurately. Now, sometimes patients will know if it's placed accurately, sometimes that they don't. Number two, the patients would hope that you avoid vital anatomy. Now, this is something that the patients will know right away. If you hit something you're not supposed to hit, they will figure it out relatively quickly. Now, as a practitioner, if I can meet expectation number one and I can meet expectation number two, I can set the stage for expectation number three, which is delivery of an ideal restoration. And in the United States, we have this saying, the implant really doesn't count. No one really cares about the implant. But if you deliver a crown that is less than expectation, that is where the patients start to have problems. So the goal of therapy, the goal of implant dentistry is to obtain all three of these patient expectations. Now, it's like I stated before, I've been practicing for quite a long time, and I've seen a lot of different types of patients. For instance, this patient right here, he comes to my practice because he had 5 or 6 implants that were placed for a fixed bridge. So I asked him, I said, what's the main problem here? And he said, Dr. Yoon, when I take this bridge out, sometimes I have trouble getting the bridge in. And sometimes when I take this bridge out and I drink water, sometimes the water gets up my nose. Now, the first thing that comes to my mind is, why the heck are you taking this bridge out? If I'm not mistaken, bridge means it's supposed to stay in. So I take a look at the panoramic image and I can clearly see that whoever placed these implants violated rule number one. They didn't put the implants in appropriately. There's too many implants on the x-rays left, and there's not enough implants on the x-rays right. So that creates kind of a cantilever effect. Here's the other thing. When the patient pulls his bridge out, what happens is that he leaves this hole in his maxilla. So the only way that he can get the bridge back in is to put that implant into that hole. Now, the last time I checked, when you pull a restoration out, the implant should not come with it. So as a result, we have some significant problems with this case because the practitioner who did the implants and did the restoration did not follow goal number one or expectation number one, which is put the implants in the right spot. And as a result, it led to treatment failure. What about hitting vital anatomy? We'll take a look at Matt. Matt was a patient in my practice for years, decides to go somewhere else for the implant. Well, Matt comes back to my practice because when he gets the restoration, he said, I get this pain on the backside of this tooth. Take a look at the clinical image. Doesn't look too bad. Restoration looks pretty nice. Implant placement doesn't look terrible. I could have shifted it, or whoever placed it could have shifted it to the mesial, maybe just a hair. But the problem was when I put him into my CT scanner and I take a look at where the implant was positioned. And when you look at the cross-sectional view, you can clearly see that the practitioner that placed the implant traversed the nasopalatine canal. So as a result, every single day, this patient has irritation on the palate. This is a situation where the practitioner did not meet patient's expectation number 2 of don't hit a vital structure. And as a result, because he did hit the vital structure, couldn't deliver the final restoration. Now, why does this occur? You know, a lot of us were trained in implant dentistry years and years and years ago. And years ago, we were taught that X-rays, two-dimensional films, were just fine. A periapical film was good. A Panorex at that time was even better. Well, those rules have significantly changed. Also, back in the day, we were taught that you had to freehand surgery. You had to know how to put an implant in without a stent, because stents back then were really not all that accurate. So we had to rely upon our eyes and our hands to make sure the implant got in the right position. Sometimes you did it right. Sometimes you ended up with results like these. This implant is clear too far to the facial. And if you even try to take this implant out, you're going to ding the adjacent tooth. So two-dimensional radiographs are no longer standard of care. We know that the two-dimensional radiograph will give you visualization from a mesial distal perspective, but it does absolutely nothing for you to tell you the buccal lingual dimension. And as a result, two-dimensional radiographs do not give us enough information to appropriately plan for an implant. Panoramic images also have a certain degree of distortion, and periapical films have a tendency to tip when you take the image. So that will lead to either foreshortening or elongation. Also, freehand surgery is no longer standard of care. When you look at the research, and this is becoming more prevalent as time goes on, the research clearly shows that when you put an implant in from a freehand perspective, you can be off by upwards of 1.27 millimeters. And that is what we call a catastrophic error. However, if you do an implant from a guided surgery perspective, your degree of error is reduced significantly down to 0.42 millimeters. So again, how we learned how to do implants in the past, those rules no longer apply because we have to meet the patient's 3 expectations. Now, I get it. In life, sometimes things aren't going to go our way. Sometimes errors are going to occur. And when you look at the realm of errors, as you can see in this image right here, this was an implant that I placed. I clearly made a mistake. You have correctable errors and you have non-correctable errors. Correctable errors are things such as small degrees of angulation that are off. So for instance, this implant that I placed in the anterior, it's less than 34 degrees off. This is correctable, not easily correctable, but it's correctable. Inappropriate spacing of implants can sometimes be correctable. The incorrect restoration, I mean, that's a reversible, correctable procedure fairly easily. You take the restoration off, you put a new one on. So correctable errors are okay because they're reversible and they can be fixed. The problem are the non-correctable errors. If you put an implant in and you deviate it greater than 34 degrees, that is a significant problem. If you place an implant and you damage anatomy, you hit the inferior alveolar nerve, you hit a bifurcation or lingual concavity, those are what we call non-correctable errors. So the goal in implant dentistry is clearly to have no errors. The goal of implant dentistry is to clearly avoid non-correctable errors. And the goal of implant dentistry is to reduce the number of correctable errors. Now, if you take a look at this case right here, again, as I mentioned, this is a correctable error. The implant is angled too far to the facial, but you know, through the good use of a prosthodontist, my prosthodontist looked at this case, uses a customizable impression coping, and uses a hyacin angled abutment and a hyacin restoration or abutment and restoration to bring everything back into alignment. And fortunately for me, the prosthodontist is able to take a less than ideal situation and turn it into a very, very nice restoration. So as I said in summary, correctable errors are okay. You want to limit them, but non-correctable errors we absolutely have to avoid. This is an example of a non-correctable error. This patient presented to me. She had these 2 implants placed by another practitioner. Now, the first mistake that was made here was you never use too many implants for a single molar site. That is just not good function. But she went ahead and had it done anyway. So I asked her, I said, what's your chief complaint? And she said, after the implant surgery, she never can feel her lip again. So I take a single film and I take a look at the periapical, and clearly the evidence is right here. The practitioner that placed these implants violated the inferior alveolar nerve space. And as a result, the patient was left with a paresthesia. When I take a look at this case from a cross-sectional view, I mean, the evidence is right there. Clearly, the top of the inferior alveolar nerve canal has been speared by this implant. This is a non-correctable error. This is a significant concern. Now, fortunately, we were able to treat this patient through a combination of some steroid therapy and low-level laser therapy as well. If you have any questions about that, please feel free to forward them to me. But non-correctable errors like this have to be avoided on a daily basis. When we look at the inferior alveolar nerve, a lot of our non-correctable errors come from this situation right here, misdiagnosis of the inferior alveolar nerve. Now, for the most part, we know what this is. We know what the nerve is. It's just a branch that provides mostly sensory and some motor innervation to the lower mandible. It's going to end in the mandibular foramen. It's going to go all the way forward and exit at the mental foramen. And for the most part, we think that the nerve is a singular object. We think that it is one nerve that runs down. However, we did some research at the Lake Erie College of Osteopathic Medicine. We looked at CT scans that were taken from 2011 to 2015. And as my students were looking at the CT scans, they came to me and they said, "Hey, Dr. Yoon, why are these nerves splitting?" And I said, "That's a really good question. I need to take a look at that." So we take a look at these nerve splits and we look at them at our little bit higher magnification, and we find that lo and behold, these things actually do exist. This is a phenomenon which is called a bifurcated or bifid inferior alveolar nerve, where your main branch comes down and a second branch comes off. And in some instances, actually a third and a fourth branch can come off. The incidence of bifurcated inferior alveolar nerves is a little higher than we expected. In the left mandible, we found inferior alveolar nerve bifurcations 7.7% of the time. On the right mandible, we found nerve bifurcations 3.6% of the time. And in 2% of our patient population, we actually found bilateral bifurcations. Now, my students also took a very hard look at two different aspects. One is the distance between the bifurcation, which we labeled GDN, and then they looked at the distance from the apex of the tooth to a bifurcation. Now, for the most part, GDN, or the distance between the bifurcations, is not really a relevant thing for us in implant dentistry, so don't worry about that one so much. But distance from the apex of the tooth to a bifurcation is a significant thing for us, for immediate implant placement and also endodontics. So when we take a look at the average distance from the apex of a tooth down to a canal on the left mandible, you will see that it is approximately 3.45 millimeters, again, from apex to bifurcation. And in the right mandible, the distance is approximately 4.85 millimeters. So when we take a look at bifurcations in summary, we have to keep in mind, number one, bifurcations do exist. Number two, the bifurcation can interfere with our implant surgery. And number three, if you do happen to hit a bifurcation, you can see things such as paresthesia, neuroma formation, bleeding. You also might have situations where patients with bifurcations need extra local anesthesia when doing the implant. And when I see a bifurcation on an X-ray, I'm automatically going and adding more anesthesia. For the most part, when I do mandibular implants, I do not do an inferior alveolar nerve block. I use local infiltration unless I see a bifurcation on the X-ray. And if I see a bifurcation on the X-ray, I'm going to consider the utilization of an inferior alveolar nerve block. As such, CBCT is mandatory for all mandibular implant cases because of the prevalence of this bifurcated inferior alveolar nerve. Now, the bifurcation is one thing, and the bifurcation is a concern, but a bigger concern is an area which is called the lingual concavity. And the lingual concavity is really a threatening issue. You cannot violate this space. When I was an oral surgeon, we were doing implants in oral surgery, we used to actually go looking for this concavity. We would do a full thickness dissection, dissect down the lingual, put an aluminum retractor down there, and drill our implant. And we knew we went too far if you would see pieces of metal coming into your osteotomy. Well, today we don't really do that. Now we use CBCT, and we always evaluate our implant sites with CBCT to look for this lingual concavity. If we look at the anatomy that's within this space, we know that there are branches of the submental and the sublingual artery that run in very close approximation to the lingual aspect of the mandible. And the problem is that if during implant placement, you perforate out the lingual and you happen to hit one of these arteries, very large hemorrhage will occur. And not only is it large hemorrhaging, it's very rapid as well, and it has to be contained in a very short period of time. Now, if you're interested in this topic, go on Google and type in these 4 words: dental implant lingual concavity. And what you will find is a ton of information will show up, a ton of information. Here's an article that talks about life-threatening hematoma after implant insertion in the anterior mandible. Case report and review of literature. What they did was they placed 2 implants in the lower canine region, and a significant issue occurred because after they put the implants in, immediate swelling of the floor of the mouth happened, which started to protrude the tongue. Now, when you start to see this, you don't have a lot of time because as the tongue is protruding and as the floor of the mouth is starting to elevate, the patient's airway is starting to get constricted. So this patient was wheeled down to the operating room and they did an emergency trach on this patient to establish an airway. Now, a lot of people sit there and say, how do you screw something like this up? Well, take a look at the CBCT. Obviously, they missed the alveolar bone. They put the implant into the lingual concavity region and it perforated the artery, leading to this type of hemorrhage. So again, detection of the lingual concavity becomes of utmost importance. All mandibular implant cases should have CBCT. And if you have a panoramic film or you have a PA and you want to try and figure out if something is wrong, look at the diameter of the inferior alveolar nerve. If the diameter of the inferior alveolar nerve, as seen on a Panorex or a periapical film, is greater than 3 millimeters, you have to start thinking twice about how you're going to approach this case. Because the average diameter of an inferior alveolar nerve is 3 millimeters. Anything greater than that means there may be a concavity. So if you look at this image right here, you can see that the patient has a large, wide canal space. So when we flip to the cross-sectional view, you can clearly see where the concavity is. And just for fun, I digitally placed an implant. And as you can see, with the digital placement of the implant in the correct restorative position, I would have caused a life-threatening hemorrhage in this patient. Now, a lot of times people in the audience will sit there and say, oh gosh, really? This concavity doesn't exist. Or maybe it's just a figment of everybody's imagination. Well, we did some research on this at Lake Erie College of Osteopathic Medicine. And what we did is we took 200 CT scans from January 1st, 2011 to August 31st, 2015. And when we looked at the CT images, we actually measured out the concavity and we classified it into 3 separate categories: parallel, convex, and concave. And the one that you want to see is the convex because that means it's going outwards. What you do not want to see is something like this, which we classified as concave. So when you look at the results, in the posterior mandible, and we classified posterior mandible as first premolar backwards, the most prevalent morphology of the mandible was concave, which means there was an undercut present, over 60-something% of cases. The anterior mandible, you have a little bit of reprieve. In the anterior mandible, it's kind of split between parallel and concave. So that basically means that some of your cases are going to be parallel, but you still, in some cases, will have the concavity you have to worry about. Unfortunately for us, most cases are not convex. They're not bulbous at the base of the mandible. So the bottom line is you got to think about this as you're going about your cases. And in order to think about this, you have to have the right equipment. You have to have the right CBCT. Your CBCT for mandibular cases must be able to do 2 things. Number 1, they must be able to offer multiple fields of view. And number 2, the software must contain something called metal artifact reduction. Now, the Osstem T2 CBCT has both. And the Osstem T2 CBCT can provide multiple fields of view. Now, the default setting on the Osstem T2 is a little bit big. So if you purchase the Osstem T2 or you have an Osstem T2, my suggestion is to set your default field of view to 12 by 9 centimeters. It's an excellent field of view. Or you can even go down to 10 by 9 if you want to, but 12 by 9 seems to do it. So when you take your scan, if you see a suspected bifurcated nerve, quite simply take another scan at 5 by 5. You need that higher resolution to actually see where this nerve may exist. Now, metal artifact reduction is very critical because with CBCTs, unfortunately, what happens is as the beam comes in and it hits the implant, it'll throw some scatter around and it'll distort your image. The MAR or metal artifact reduction on the Osstem T2 is superior to a lot of other companies that I've seen. And as you can see here on the image on the upper right, this is what a scan looks like without the MAR technology. But if you turn the MAR technology on, you can see a distinct reduction in scatter. So again, when you're looking at a checklist for mandibular implant surgery, you're going to do an implant on the lower jaw. What do you need? You need an Osstem T2 with a CBCT of 12 by 9 or 10 by 9. You need a CBCT guided surgical stent so you can put these implants in appropriately. And you need a kit to make sure that these implants go in the right direction. And for me, I use the Osstem Hyacinth One Guide kit. So let me give you an example. Meet Troy. Troy was a 27-year-old Asian male that presented to my practice. And he said, I really want a tooth. And when I'm looking at this case, I take a quick periapical film. The first thing that I see is that canal space. That canal space is clearly wider than 3 millimeters. So I'm instantaneously going to put him in the CT scanner to see what I have to work with. Now, when I put him in the CT scanner, I get another little thing that gets thrown at me. He's got a buccal defect. So now I've got to make a determination. I've got buccal defect. I've got a huge lingual concavity sitting here. How am I going to approach this case? What am I going to do? Do I do a ridge augmentation first? Do I forego it and do a 3-unit bridge? Well, the nice thing about CBCT and the nice thing about software is you can do the surgery on the computer as many times as you want, and no one's going to complain. So I'm going to put different implants in. I'm going to try different sizes in. And ultimately what I settle upon is a 4.5 by 8.5. I'm going to tip it slightly. I'm well below 34 degrees. I'm going to engage the lingual cortex, but I know I'm going to be safe. I'm going to put the implant about 2 millimeters subcrestal on the lingual, and I'm going to put it completely crestal at the buccal. We're going to trace a crown into position to make sure that it's going to be restorable. And if everything looks good, we're going to proceed to day of surgery. When you take a look at Troy on day of surgery, you can clearly see where the buccal deficiency is. So we're going to go through and get our surgical stent and try our surgical stent into position. Now, when I try my surgical stents into position, I always look at the window. And if you look at the left image on my screen, you will see the incisal edge sticking out of this little window. You want to make sure that's seated all the way down. If it is not seated all the way down, send the stent back. That's a processing error. We do not want to adjust that. Send that back to the company so they can remanufacture it. The first drill that we use for the one guide surgery is a tissue punch, and this is truly flapless surgery. And I'm going to trust the flapless surgery because I've already planned this out on the CT scan. Now, what you'll notice is with the punch, I completely obliterated the keratinized tissue. But watch what happens a little bit later on during the surgery. I was actually fairly surprised when I got the results back. So we're going to remove the tissue plug. We're going to put the stent back on, and we're going to use the 1-2-2 drilling sequence. It's a 3-drill system, which is named 1-2-2. The first drill is what's called the initial drill, and this is just used to slightly open up the osteotomy site. All the drills are going to be controlled by the stent, not only from a buccal lingual perspective, but also from a mesial distal and depth. If you can put the barrel in the hole, you can do implants at this point in time. We're going to follow it up with the 3.5 by 8.5 drill, again, just making the osteotomy a little bit bigger. And then we're going to finish it off with the 4.5 by 8.5 drill. Now, at this point in time, my osteotomy is complete. And I just want to make sure that everything is going according to plan. So I'm going to take the stent off. I'm going to take a depth gauge, not a perio probe. I'm going to use a depth gauge. and I'm going to palpate the bottom of the osteotomy to make sure it is still intact. Now I feel it, everything is intact. I'm also going to look at the patient's floor of the mouth to make sure it's not elevated. And I'm going to talk to the patient. I'm going to say, how are you doing? He said, I'm doing just fine. So I know that the placement of the osteotomy is safe. We're going to mount up a 4.5 by 8.5 Hyacin NH implant, and we're going to slowly torque this into position. So your drills are controlled and your implant placement is controlled 100% by the surgical stent. We're going to slowly torque this implant in at 35 Newton centimeters. And we know that we are at the appropriate depth when you see the yellow lines are flush with the stent. There is no stopper with the implant mounts. It's actually designed on that like that for purpose. But when the top of the yellow lines are flush with the stent, you are at your appropriate depth. And when you look at the appropriate depth and you pull everything off, this is the way it's going to look. Now, a lot of people ask me, at this point, do you one stage or do you two stage the implant? And for me, for most of my cases, I actually am a little bit old school and I go two stage. Because remember, I wiped out or I got rid of all the keratinized tissue with my initial punch incision. I'm hoping I'm going to get some of this back. Well, the proof is in the clinical images. And as you can see here at the 2-week mark, I'm already starting to regenerate back most of the keratinized tissue that I've lost. I've been doing this exact same technique ever since I got the one-guide kit. Two-staging my surgery, I don't worry about the keratinized tissue, and I've found the regeneration occurs very predictably. So it does involve a second step for the implant uncovery, but for the most part, when I do it this way, I get the appropriate tissue that I need for gingival protection on the implant and appropriate aesthetics. The patient's going to come back and we're going to do a small incision, displace the tissue to the facial and place a healing abutment. And at this point in time, it's now set for me to send to my prosthodontist. My prosthodontist is going to temporize the case. And at this stage, you're going to notice there is blanching on the gingival tissues, and that is okay. Blanching on gingival tissues is okay, so long as the blanching goes away after 15 minutes. So you put your healing abutment in or you put your temporary in, get up, walk around your office, and come back. If in 15 minutes the color returns completely, you're fine. If after 15 minutes the color does not return, you need to either use a narrower diameter healing abutment or you need to contour your temporary so that it's not putting so much pressure on the gingiva. This is a very critical step. Gingiva that is not returned back to color after 15 minutes is dying gingiva at that time. So in this situation, the color returned. My prosthodontist is going to leave him in a temper for about 2 or 3 weeks and then proceed to final restoration. And as you can see with the final restoration, we've obtained all of our goals. The implant is placed in the appropriate spot. We did not hit any vital structures, and we were able to deliver an ideal restoration. If you want to see this case in full, we did publish this case in Compendium. You can go on Google and type in Yoon guided surgery, buccal defect, lingual concavity. It's a lot of search terms to put in there. But if you do, you will find that we published this in Compendium April 2019, volume 40, issue 4. We talked about a lot of different things today. But the most important thing to understand is that in today's day and age, patients expect safe and accurate implant surgery. They know what their expectations are, and after this lecture, you now know what the expectations are as well. As a result, CBCT is mandatory for implant cases. In the United States, if you do not get a CBCT, you are actually practicing below standard of care. When you get your CBCT, look for structures such as nerve bifurcations and look for things such as mandibular undercuts. Avoid them, design your case on the computer, do your CT analysis, treatment plan a one-guide surgical stent, use the one-guide kit to increase the safety and accuracy of your implant surgery. And if you can accomplish all 3 of the patient expectations, you will always have a successful implant practice. I would like to thank everybody for the time to present today. I will be around to answer any questions. If anybody has any, again, I'll be more than happy to answer. Thank you guys so much for the time to present. Have a nice afternoon. Thank you so much.